All right, let's go ahead and get started. Hi, everyone. Welcome to today's session. We are covering HIPAA compliance, more than just a checkbox. My name is Amber Matta. I am your moderator for today. I am the marketing manager here at Cybersecurity, and I'm very excited for you to hear what we have to share today. In case you're not aware, at Cybersecurity, we are a managed security service provider, and so we're dedicated to protecting SMBs and nonprofits from those ever-increasing cyber threats and helping comply with the latest cybersecurity regulatory requirements. During this session, if you look on the bottom of your screen, there's a Q&A button. So if you have any questions or comments during the session, please feel free to utilize that button. We'd love to hear from you. The message will only get sent straight to Bob and I, and so we will address all the questions at the end. Of course, at the end, we will also have a recorded version of this webinar, so I will be able to get you that link by the end of today. It will actually be posted on our YouTube channel where there's a lot of other webinars and other links as well if you want to check that out. And of course, as marketing manager, it's pretty much my duty to get the chance to expose you to our social sites while I have the chance. So after today's webinar, please feel free to keep in touch with us via social media and our blogs. We do post really cool stories and other topics, and you'll find it pretty interesting. So finally, I'd really like to introduce the person which you've come here to listen to, which is our presenter today, Bob Thomas. Bob wears a lot of hats here at Kyber, but officially he is our VCIO and our VCISO. Today he's going to share with you our solution for small practice HIPAA compliance and data security. Welcome, Bob.
Thank you very much, Amber. Good afternoon, everybody. Thanks very much for joining us today, and I hope I can impart a little knowledge about HIPAA compliance and how the program that we use works. So I'm going to be quick about some of this stuff because it's probably known information for a lot of you, but I thought it was worth explaining. Something that a lot of folks don't really think about is how this HIPAA Act came to be. Came from back in 1996 when it was put into place. It actually didn't really take effect officially until 2003. But that whole portability thing, everybody's probably curious why it's health insurance portability and accountability. That's the part that gets forgotten, so it's worth 10 seconds of mention. That's actually so you can go from job to job, company to company, and actually have the ability to take insurance with you and not be in an uncovered state. The Accountability Act is what everybody seems to focus on, and that's security of the patient information, whether that be their historical health condition or any treatments they're receiving or future results to that. It was really, I think that's what everybody focuses on, PHI, personal health information, and electronic personal health information, and that's what everybody is trying to spend effort in closing any gaps and really focusing on security and privacy of that information. I think probably everybody can agree that the rules are somewhat vague. It's been that way, it seems intentionally, mostly because what's good for a small practice probably doesn't match up with what meets the needs of a hospital or an insurance provider. So that's why people have to read between the lines on some of this with respect to the rules of the HITECH Act, which is what it was called in 2013. At the end of our presentation, we're going to be able to put up a link. It's an online tool that HHS, the Health and Human Services Department, makes available, and that HHS department has created a very quick 2-question survey that will determine whether you are covered under the HIPAA regulations, deemed a quote-unquote covered entity, which is the term that a lot of folks will see in writing. You answer those questions and it will automatically pop up a result to say, yes, I am a covered entity, or you're not. And one other thing that bears mention is most of the vagaries inside the HIPAA regulations were changed, and some of the loopholes were plugged in 2013. A lot of folks call that the HITECH Act, others call it the Omnibus, but at that point, I think the government saw that people were trying to circumvent the rules and basically not just avoid the rules, but find ways of following the guidelines without going too far with respect to security. And I'll give you an example of that. We have a client who they've been a client of ours for a very long time, and they're pretty tech savvy, and they read the rules and regulations before 2013, and it said that people had to have a firewall. That was a requirement. Nothing was in writing that the firewall ever had to be actually installed and implemented. So what did they do? They bought a firewall, they stuck it on the shelf, it was still in the box in the wrapper, until the rules of 2013 rolled out, where they plugged that gap, if you want to call it a loophole, and it said not only do you have to have a firewall to protect your information and secure your connection to the internet, but it has to be implemented, has to be up to date, and constantly updated. So those are the types of things that were changed as time went on. There's been a few updates to the HIPAA regulations, and that's the most recent major one was 2013. We're going to go through a little Mythbuster session here, and these are questions that I think quite a few practices talk about and ask themselves and mention. PHI, personal health information, is only in our medical record system. So we don't have to really worry about where it's located, because that's where everything is stored. I think that's a utopian idea, that it would be located locally in that system. It could be on a cloud system as well. But I think the real point is, how does it get there? How does it actually make its way into the electronic health record system? And in a lot of circumstances, it's not just from people entering data at the point of care. I think more often than not, we could talk about it as something as simple as a document comes in the mail, a referral document from a general practitioner to a specialist. That happens every day in practices, and snail mail is still a very common way of those documents making their way from practice to practice. It's on paper. Yes, I bet it gets scanned into the system someplace and hopefully uploaded directly into the patient's chart. But I think the real question is, what happens with that piece of paper? How does it get to you? What happens once it's been scanned? If it's been scanned using a copier, that copier could have storage locally on a hard drive. These are all things that are typical ways of storing data, but it's not just in that electronic medical record system. Fax, e-fax, those are all methods of moving data around where it's outside of the medical record system. I think the next myth is I completed a risk assessment, so I must be compliant. I don't think I could say anything could be further from the truth at this point. I think that's a good first step, is doing, and it's an annual risk assessment. This is not I just do it once and I'm done with it and I don't look back at it, because it is evolving. But a risk assessment is to determine how secure your environment is, how many controls you have or do not have in place to protect the privacy of that patient health information. And I think this ties together with last year's risk assessment will suffice. Well, if you had gaps last year, and those gaps, obviously there should be a plan to mitigate those issues. A year post initial assessment, there should be changes, and another assessment should be done at that point to determine exactly what's changed in your environment, what's improved. And this should be a plan over time, a phased-in approach of solving those gaps and providing over time better and better security. And here, this is a kind of an interesting one, the biggest myth of them all. We're too small. This will never affect me. I did some research, and we're going to have some statistics after this, but I just found one this morning. A one-person physical therapy location out in Los Angeles was fined $25,000 by OCR. That's the Office for Civil Rights. That's a division of Health and Human Services. And why were they fined $25,000? It would seem, extreme for one medical practice provider. They took photos and people's first and last names and potentially even medical conditions and posted them on their website for marketing. That was how they were trying to build their business. So they were essentially they were putting out information, patient health information protected. The big problem that they had and that they created, they didn't actually get permission from the patients to be able to do that. They've gotten releases. This probably would have been a non-issue, but that a complaint was lobbied against them with OCR, and that's how it came to be. So that link that I talked about, it basically explains what's on the screen. Any entity that furnishes bills or receives payment for healthcare in the normal course of business and sends any transactions electronically. That is the determining factor for whether you are or you are not a covered entity. And we'll send you a link that Amber's going to post something in the chat box at some point that is, I'm sorry?
No.
Yes, great, there. So you can walk through, it couldn't be any easier. There's two questions. You answer the two questions with a yes or no, and it will guide you through and answer whether you are a covered entity or not. But the mission is, if you're, regardless if you're a covered entity or not, you're providing healthcare and you are storing people's patient information. It's, as it says on the screen, it's good business to protect that data, all of that data. It's an ongoing process that needs to be done over time. New issues with security pop up every single day. We read about them in the papers. We get email blasted about them. We're here to help try and plug those gaps. That's really the mission of being compliant and striving for compliance. Here, I'm just going to pop up these three. I'm not going to talk in depth about them, but these are local, regional practices that were hit with violations or tracked with violations and hit with fines in the last year. These are not huge institutions, and they're not really, in the grand scheme of things, these are not very big breaches. 1,500, 3,000 pieces of data being out there for patients, that's not a large practice or a large leak out of data. So I think it's important to know that the Office for Civil Rights is not targeting just hospitals or just something like Aetna or Anthem or Cigna, any of the big healthcare providers. They are looking everywhere to make sure that people are following the regulations. This is something that Amber put this presentation together. I think this is a great slide that talks about, I think, very obvious potential issues with just about anyone's network and their access to PHI or EPHI. We were looking at this yesterday, and I was drawn to actually number 10, which sounds odd, home computer access, but Amber and I were talking about it. And the first thing that came to mind with me is, well, I'm using a secure connection. I'm using VPN, virtual private network, to link my home office to my practice location or to a cloud location for accessing electronic health records. Well, that sounds perfect. You're doing the right thing. The issue is you've got somebody's medical record information up on your screen. You walk away, you take a phone call, you go to the refrigerator, you heat up your coffee, and that information is sitting up there on the screen for anyone inside your household to walk by and read. That is a violation. You're not, locking the screen. You're not automatically enabling a screensaver after 1 minute of inactivity or, some very short number. That's a gap. That's a problem. And it's very easy to have that type of problem with home computer access because maybe it's not being controlled by the home office and there isn't enough security applied to that device. untrained employees, we're going to hit this a couple of times, but I think that's, I think these two things almost go together. If an employee thinks they're secure because of the way they're accessing the information, but they walk away from a machine and don't lock it, they're leaving data available for anyone to look at. And untrained employees, it could be that type of access. It could be they're using a laptop and walking out the door with that laptop, but the data that's sitting on that laptop that they're working on at night or off hours or over the weekend is not encrypted. So anybody that grabs a hold of that laptop can open it up and they'll have access to patient data. The laptop gets stolen, car gets broken into because they left it in there while they went into the grocery store on the way home. All sorts of things can happen. And trust me when I can tell you, I could go through every one of these and we could fire off how these affect any particular practice. But these are the typical ones that we see every day that we try to help people with. So let's talk a little bit about how we try to get people to compliancy, how our program works. And I think the most important thing, and I said this once before, this is not a one and done project. This is not, oh, pick a point in time, I'm going to take the assessment, we're going to try to remedy whatever is outstanding as a gap in the assessment, and that's it. And stick it in a file drawer, and I'm done. This is constantly evolving. And with some practices, what we've seen is the gaps are so significant that there's no way you could take all of them on at once and plug all of the gaps in one point in time. It's just not realistic. And I think, where we come in, we're trying to guide folks through the process. Yes, we can help and guide through answering questions with respect to the assessment. But our value really comes in after the assessment, once that whole questionnaire is filled out and we've got a report to deal with, and that report says, here are the issues, and now we need to prioritize those issues. How are we going to solve them? What's it going to take to solve them? And which ones are the most important ones? Which are the glaring errors in the environment that have to get fixed and have to get fixed in the near term? That's really where we're focusing our effort. And this probably reiterates the process. So there's one thing that's kind of missed in this. Yeah, a profile has to be created. These are all done through a portal that we have available. Once that company profile that talks about what type of practice, who are the key players, the administrators, and exactly how many locations and how do you practice, then we go to a risk assessment, which is I don't want to say a fairly lengthy, but it's a good-sized questionnaire that talks about handling of patient data. How are records kept? How are you accessing the internet? What type of equipment do you have protecting your internet connection? How do you back up your data? Do you have a recovery plan in place? Has it been tested? All of these things that are important, not just towards the privacy of the data, but day-to-day functionality of the practice. Once that assessment has been processed and all the answers have been culled through and a report is generated, that report will give us what is on the screen as a gap assessment. It's going to determine exactly what problems exist, and it will actually give us some idea of what level of risk they are, and that's going to come up in the next slide. We're going to talk a little bit about risk level and what how you should prioritize. And then obviously the last part, once there's a gap assessment and the gaps are documented, we need to remediate the problems, and that's part of that plan that I was referring to. We've got a plan, and that plan says that within the next 6 months, we're going to solve this problem. Once that's done, we're going to go on to phase 2 and solve that. And maybe it'll take a year, maybe it'll take 2 years, depending on what the issues are. And that remediation is us getting involved, whether it be project work or guiding you through a quote-unquote work plan, because that's really what it's called at the end of the day. This is how the risk charts out. There's on the left-hand side of the pane, there's a probability, how how likely is something to occur? And I'll give you the example at the bottom as soon as I get through the slide. And on the right, what the overall impact is. And impact is impact to the practice, impact on PHI or EPHI. Is this one chart that is potentially being impacted with data risk or loss, or is it the entire volume of charts for the entire practice for a particular location, all locations? So you see down the bottom there, we put in a threat there, a stolen or lost smartphone, which may contain EPHI. And then based on what that device is and how it would typically be used, the probability of it happening is medium. I guess, depending on how careless someone is, it may be medium, it may be high, depending on if they tend to leave stuff around. But the real important part is what's the impact, what is the impact and the risk? And those are rated with this type of devices as medium. And I think each device you've got to determine, is it accessing PHI or is it storing PHI? And that, if it is truly, they're obviously smartphones have gotten very advanced. There's the ability to, I'll give you a simple one. Somebody takes a picture of a chart because they want to be able to upload it to some other system because they're trying to get an insurance claim resolved. Okay, they take the picture, they upload it, or maybe they've even got a faxing system built into an app on their smartphone and they fax it to someone, but they leave the picture there. And the picture's there forever. And then the picture may be somebody else, someplace else. It could be stored up in, let's say, Google's cloud, Apple's iCloud. And now it's in multiple places and it's not encrypted. Those are all risks that determine what the risk factor is and how likely it is that something will happen. And I think we could probably come up with multiple examples, and we're going to talk a little bit about these. In this one, we've got several different issues. We're going to talk about smartphones, which we just mentioned. Whether the smartphone's encrypted, and if it is, that's great. There's even you go a step further. Is it encrypted, and do you have the capability of wiping it if it falls into the wrong hands, or simply the employee leaves and it's a personal phone? Do you have the ability to wipe the business content of it? One of the things that really jumps out, we talked about employee training. Lack of employee training can lead to security breaches, and the control and everything within the HIPAA compliancy world talks about controls and security. Security training and reminders for the entire workforce. This, we've got a sample here that says no, and this is a requirement. You've got to, this isn't just training new employees when they come on. Absolutely, that needs to be done. They've got to have awareness as to how to handle files, how to handle patient data, how to avoid mishandling of that data. We talked about scanning the simple documents, referral letters in. That information goes into a system. What did they do with the piece of paper? Were they trained to put that in the large locked shredder box so that nobody else has access to it? The cleaning people can't walk by the trash, go to empty it, and peel somebody's medical record right off the top of their trash bin. All of those things go to security training. We call it security training because that's really what it is. It's securing the records for all of the patients in the practice. And this is not just staff members. This is doctors have got to be trained too. And again, not once, this is annually. There has to be a system. You want to do it with a checklist? I suppose it could be done that way, but there needs to be a way that it's verified that everybody has gone through the training. They've tested out of it because there are tests, quizzes, if you will, at the end of each module. And that is how OCR can determine, were you in violation because no one was trained, and that's how the medical records were leaked out. That's really what they're trying to determine. The fines, that they levy are not just, okay, how many records were affected. That's a portion of it, because it is a multiplication. They take number of records times a fine number. And the maximum is $1.5 million per year, I think is the number. Well, if you think about it, if you had a plan, you did training, and all of the right things were accomplished, but somebody slipped up, they are going to be much more lenient if you had a complete plan and a security program in place, rather than being very blasé about it and say, oh yeah, well, we train people when it's necessary. Well, that's not a plan, and that's not a policy. So it's very important, and here it talks about security training and reminders for the entire workforce. The HIPAA security rules, security awareness and training standards states that an organization must implement a security awareness and training program for all members of its workforce, including management. I wish that said including management and providers. This is not just staff workers, not receptionists, not back office. It's everyone, and workforce members with a periodic security reminders. This is annual. That is the right time. Now, somebody comes on in the middle of the year, and you've done something for the rest of the staff at the beginning of the year. They get tested immediately as part of that training, and then follow up a year from then. It doesn't have to have everybody on that same schedule. And just to follow up with remediation. So Health and Human Services, when they rolled out the whole HIPAA Act, they broke it down into roughly 3 categories. We've got administrative types of procedures. I would call that more policies and process, how you deal with staff, how you deal with vendors, business associates agreements, and the requirements for those. Having a plan, it says DR, disaster recovery, what do you do in the event of an issue? Those are administrative procedures where you have to have written policies and a process for following them. We've got physical. I think physical is probably obvious, but you need to have potentially access control system, and maybe that access isn't every single door, but it's certainly, if you have a server and a network environment, you've got to have that door locked. There's got to be only certain people that have access to it. We've been talking about security training. That probably falls under here because you're talking about document handling. We haven't talked about PHI tracking and disposal, whether it be paper-based or ePHI, and how you delete and what's the proper method for deleting. Those are all important things, and patching and malware, all the cybersecurity pieces that we're protecting folks from every day. And then there's a technical component, and that technical piece is all of the stuff, let's say, that makes and enforces the security of the system. We talked a little bit about encryption. Encryption, critical when we talk about external drives, people taking little thumb drives. They're cheap as all get out now. They store a ton of data, and people walk around with these things all the time. Those things need to be encrypted. You need to have a firewall, mandatory. Smartphones, you need to be very careful how you deal with data on smartphones. These are all pieces that make up the technical component. The takeaway, reliance on user input. You've got, this is funny, when I first saw Amber did this, I was laughing. You really have 2 ways of looking at this. You take the assessment, you answer it honestly with quality and accurate information so that you have a true assessment of your environment and to understand where your gaps are and be able to provide a real solution to a problem, or just check yes to everything and hope that HHS/OCR never comes knocking on your door. If they do, it will be a bad day, because they will know that you didn't answer truthfully and that you were trying to avoid spending any effort on compliance. I think that's all we have today, except for questions and answers, and I have to look over at Amber and say, do we have any questions?
We do. We have a couple.
Okay.
Okay. So the first one we have is, Do I have to have my staff and contractors on my email system, or can they just use their own personal email?
We've actually, we've seen this in a couple of assessments already that we've done for folks where they have, it's mostly a contractor problem where they're hiring, maybe visiting nurses or home health aides as part of how they deliver service. And they're exchanging, I can't believe they're doing this, but they are actually exchanging protected health information via email, unencrypted, problem number one, but also on the, let's say the far end, the tail end, they're doing it from personal email accounts, Yahoo, Outlook.com, or Hotmail back in the day, Google, whatever their personal email is, that's what they're generating the messages from. That is a no-no. I can't think of a single way that we can secure that environment. There's just no possible way, because we have, as an organization, no access, just like the practice has no access, to that mailbox. The person leaves, is no longer working, they take their mailbox with them, and all the data is gone and outside of your control. That's a problem.
Cool.
Big problem.
I think I have a couple more, so let's see if we can quickly address them. The next is, if I start your process and before I'm done, I have a breach and get audited, will I still be fined?
I would say that the fines will be less than they would have been if there was no process in place, what OCR wants to see is that you are concerned about security and you are working towards compliancy and a resolution to gaps. That's what they want to make sure, that this is not breach with intent. They don't want to see somebody basically running a very loose and free organization where data is everywhere and, oh, well, it happens to everybody, so I'm not going to worry about it. That is exactly the opposite of what they want to see. So I would say there's a possibility of a fine, but I would absolutely believe that the fines will be reduced because of, let's say, wheels in motion.
Okay. And let's do just one more, just for time's sake.
Sure. We can answer others offline if there are more coming in, and we can send those out to everybody afterwards.
How often do you recommend conducting employee awareness training?
I think it's got to be once a year. I think that's, I think if you talk to any of the vendors out there and the security providers, that's the standard. I think my only exception to that is if we have a repeat offender. I mean, the way security awareness training works is an assessment is done, and it's usually some sort of email phishing campaign that is not announced to anyone, is done behind the scenes. People get emails, and it's really a test. Are they clicking on, are they opening them? Are they forwarding them? Are they opening attachments? And we get a report on exactly what every user did as part of that training. That report will tell us who did what, how far they took it, and those reports concatenate. They work in conjunction with each other as time goes on. So if we've got somebody that is a problem and they've gone through the training, which also involves some sort of testing component of it as well, after that, they are going to get retested. And I think people that are quote unquote repeat offenders could be tested and trained more often than once a year. I think in almost every organization there might be one or two that could fall into that bucket of needing more than just a one-off training.
There's always those extras.
Yes, there's always one in a crowd. That's absolutely true. But I do think at least annually it has to be done across the board for the entire practice.
Great. Well, thank you, Bob, and thank you to all of our attendees today. Again, I will be sending you the link to this recording at the end. And if anyone else has any questions, I will address them afterwards. You can quickly send me an email if you want, or give me a call, whatever you want to do. But thank you for attending. Have a good day.